أعوذ بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم. يا أيها الذين آمنوا لا تكونوا كالذين آذوا موسى فبرأه الله مما قالوا وكان عند الله وجيها. يا أيها الذين آمنوا اتقوا الله وقولوا قولا سديدا يصلح لكم أعمالكم ويغفر لكم ذنوبكم ومن يطع الله ورسوله فقد فاز فوزا عظيما. إنا عرضنا الأمانة على السماوات والأرض والجبال فأبين أن يحملنها وأشفقن منها وحملها الإنسان إنه كان ظلوما جهولا. ليعذب الله المنافقين والمنافقات والمشركين والمشركات ويتوب الله على المؤمنين والمؤمنات وكان الله غفورا رحيما. صدق الله العظيم.
O believers, do not be like those who slandered Musa alayhi salam, but Allah cleared him of what they said, and he was honorable in the sight of Allah. O believers, be mindful of Allah and say what is right. He will bless your deeds for you and forgive your sins, and whoever obeys Allah and His Messenger, he has truly achieved a great triumph. Indeed, we offer the trust to the heavens and the earth and the mountains, but they all declined to hear it, being fearful of it. But humanity assumed it, for they are truly wrongful to themselves and ignorant of the consequences. So that Allah will punish hypocrite men and women and polytheistic men and women, and Allah will turn in mercy to believing men and women. For Allah is all forgiving, most merciful. Jazakallah.
Jazakallah. It's a pleasure to be here with you all today to discuss a topic that is very near and dear to me: hospice and palliative care in Islam. As a palliative nurse practitioner, I have the privilege of working alongside patients and families during some of the most vulnerable and sacred moments of their lives. Not only about mental care, but about meaning, dignity, and faith. For Muslims, the end of life is not simply a medical reality, but a deep spiritual journey guided by the principles of compassion, mercy, and trust in Allah's decree. Tonight, we will explore how Islamic teachings align with the philosophy of palliative and hospice care, focusing on relieving suffering, honoring patient dignity, and supporting families. Our goal is to provide a framework that integrates medical practice with Islamic ethics, so that healthcare providers, patients, and families can find guidance, comfort, and reassurance during the most important stages of life. I'd like to first introduce our guest speaker, Dr. Asma Fazal. She is a senior clinical anesthetist at Advocate Health Illinois and Wisconsin Division. Her areas of research are Islamic bioethics, organ donation, and transplantation in refugee and migrant health.
Assalamu alaikum. Subhanaka la ilma lana illa ma 'allamtana innaka antal alimul hakim. Rabbi shrah li sadri wa yassir li amri wahlul 'uqdatam min lisani yafqahu qawli. Today, I am very grateful to all of you that you are spending your evening here listening to me and learning about the Islamic principles at end of life. In my presentation, I'll go through a few definitions, few principles that build the foundation of end of life care in Islam. So what is clinical ethics? Clinical ethics is a field of study that helps health professionals make good decisions when they face difficult or complex situations in their work. It is based on some important values such as respect, fairness, and compassion that guides the healthcare professional to act in the best interest of their patients and society. It also helps health professionals communicate with the patients, their colleagues, and families in an honest and respectful way. Islam considered access to healthcare as a fundamental right of the individual. Since the second half of 20th century, medical ethics has become a relatively new topic for Islamic ethics and Islamic scholars, resulting in engaging discussions throughout the Islamic world. Islamic medical ethics is the method of analyzing and resolving the ethical issues that arise in healthcare on the Islamic moral principles and legislative sources, that is Sharia. It is important to note that the term bioethics is new and the names of former principles is new to Islamic world, but the foundation was laid 1400 years ago. So, as I mentioned, Islamic bioethics is the extension of Sharia, that is the Islamic law, which itself is based on Quran and Sunnah. When no clear rule is found in the Quran and Sunnah, ijtihad or qiyas is contemplated. Ijtihad is religious reasoning. In the later period, this consensus included the agreement of the learned scholars, the ulama, along with medical scientists like physicians, who are regarded as the most learned and most knowledgeable people in the opinion, and they formed their collective agreement in the form of, fatwas, and they addressed the evolving ethical issues in the field. Just like Western bioethics, Islamic medical ethics uphold the 4 principles, but these principles were outlined by Quran and Sunnah 1500 years ago, before Hippocrates and Busham and Childress. However, there are some differences in the applications of these principles. So these are the 4 principles according to Western bioethics, but these are the same principles that we use in Islamic bioethics. So, as I mentioned, I will just go through the basic concepts and principles so that we understand what I will be mentioning later in my presentation. So, autonomy is the right of self-determination. From Islamic medical ethics perspective, patient autonomy, their ability to make decisions for themselves, is paramount. Every patient has a right to make decisions for themselves. But it is also important to determine if they have the mental ability to make the decision. Usually, we use the term decision-making capacity. A patient with decision-making capacity should be the first to be consulted about their health condition, including delivery of the bad news. Their preferences and expressed will must be honored, even if their family disagree. I want to emphasize on this point because I know that in South Asian families, we usually do not want to tell our loved one who is sick about a bad news or a bad prognosis. This is prohibited in Islam. A patient has the right to know about their prognosis, their diagnosis, or what the treatment team is planning in terms of their treatment. Advanced directives like written preferences, power of attorney documents, they may be required. The patient can appoint and must appoint a proxy, a surrogate decision maker to act in their name if they become incapacitated, like they lose the capacity to make decisions for themselves. Patient family should respect the law of the land regarding the surrogacy hierarchy. So surrogacy hierarchy is like if the patient is unable to make the decision, who should be the next person to make the decision for the patient? So we are in Illinois. So Illinois surrogate decision-making hierarchy says that if the patient has a legal guardian, they should be the first one to make the decisions. If they do not have a legal guardian, then a spouse or civil union partner, as defined in Illinois law, adult son or daughter, parent of the patient, adult brother or sister, adult grandchild, close friends. Most of the time, when I get consulted, they say that we do not have anybody for the patient. Like there is no family available. So we ask the social workers to look for any neighbor or a friend who can make decisions for themselves. And it is per Illinois surrogacy hierarchy. And if we have nobody and we have to make time-sensitive decisions, then the legal guardian of patient state can make the decision for them. Disclosure of medical information. Patients have the right to know about their health conditions. all good and all bad information, but equally have the right not to know or delegate decision-making to someone else. In our communities, families often are closely involved in clinical decision-making, and if a patient does not have the mental ability to make decisions for themselves, often a family member helps their family with necessary decisions. At certain times, family may request the clinician not to share certain diagnoses with a decisional patient. In such cases, openly exploring the patient's input in how they would like their healthcare information shared can preserve patient's autonomy and cultural preferences. So in simple words, if the patient is able to make decisions from themselves, and if the family is asking us, the care team, not to share the medical information with the patient, we are obligated to share it. And this is per Islamic law too. If the patient is not able to make the decision, then it's a different question. Then we'll go with what the surrogate is saying. If the patient is able to make the decision, but they are saying, oh, I don't want to make the decision. I don't want to know anything about it. Talk to my son. And I have had several cases where this has happened. And our nurses, in the Western environment, they were like, this is not right. Help us. What is happening? In those situations, we tell them that we have to be culturally sensitive to that patient, but ask the patient if they want to delegate their decision-making to their son. And we have to make sure that the patient is making those decisions voluntarily without anyone's pressure. Beneficence. Allah says in Surah Az-Zalzala, verse 7 to 8, whoever does an atom's weight of good will see it, and whoever does an atom weight of evil will see it. Beneficence is an act of mercy, kindness, and charity. So this is a second principle of bioethics. In Islamic jurisprudence, avoiding harm takes precedence over bringing good. So you have to avoid harm at any cost, no matter how much good it is bringing. So there's a balance. So if the harm is higher and the good is lower, so you have to prevent that harm from happening. Sometimes there are treatments in which say, yeah, there is some benefits, but there are harms as well. Don't go with the benefit. You have to avoid that harm at any cost. All that is harmful is prohibited in Sharia. Obligations of preventing harm do not just relate to obligations not to harm another, but also includes obligation not to impose the risk of harm, particularly with regards to treatment and non-treatment decisions like vaccination and the general population. When I was studying, I was told that this principle of non-maleficence, do no harm, is from David Miller. But then when I started studying Islamic bioethics, I learned that no, it was from Prophet Muhammad sallallahu alaihi wasallam. Prophet Muhammad sallallahu alaihi wasallam said, doing harm and reciprocating harm is not allowed. Muslim jurists have been mathematical in their judgment about this, such as the action must be taken if the benefit outweigh harm by even 1%. Harm should be removed to what is possible. Harm should not be removed by another harm, saying that, oh, the harm is little in this one, and this one has a bigger harm, so let's go with the little harm. No, the harm needs to be removed. A more severe harm is to be removed at any cost. Harm to an individual is tolerated in removing a public harm. Again, going back to the example of vaccination. People say, no, I don't believe in vaccination, so I won't do that. But we know that if the person is not going to get vaccinated, they are going to infect the whole community. So in these circumstances, Islam being a social construct of life and a way of life, Islam says no. Here, you are not going to respect the autonomy of the patient. You are looking and make sure that the bigger community is not being harmed. So again, the public health and individual health, there has to be a balance. As we are talking about end-of-life care and withholding and withdrawing treatment, we'll be talking about later. So in these situations, we have to we have to weigh the benefits and burdens of treatment. And when I get consulted for any patient, I always ask them, if you are continuing the patient on ventilator, is the patient going to get benefit from that, or are the harms higher than the benefits? So again, bringing those principles to Islamic bioethics, Islam says the same thing. If the benefits are higher, go ahead. If the harms are higher than the benefits, don't do that. The first main principle of Islamic medicine is sanctity of human life, which derives from the glorious Quran. Allah says in Surah Ma'idah, verse 32, whoever saves a human life, saves the life of the whole mankind. The second main principle is the emphasis on seeking a cure. This derives from a saying of Prophet Muhammad sallallahu alaihi wasallam in Sahih al-Bukhari, book 71, hadith 582. There is no disease that Allah has created except that He has also created its treatment. Prophet Muhammad sallallahu alaihi wasallam in another narration reported to have said, seek treatment, O servants of Allah. For Allah the Exalted did not create a disease for which He did not create a treatment except aging. So you can see there is so much emphasis on seeking the treatment and preventing yourself from declining. This also mentions and reject the concept that we have in our community that, oh, this is Allah's will. Allah की मर्जी है हमारी बीमारी. हमें ज़रूरत नहीं है treatment की. No. Allah, our body, our life is an amana that we have to return to Allah. Allah and Prophet Muhammad sallallahu alaihi wasallam has clearly said that you need to seek treatment so that you get cured, because there is a purpose that Allah Ta'ala has sent us in this world. So we cannot dictate our life, make choices that are not permissible in Islam. So treatment is obligatory, wajib, when it can significantly extend someone's life in a meaningful way. What is meaningful way? We are sent in this earth to pray, to obey Allah subhanahu wa ta'ala, to follow the principle that Rasulullah sallallahu alaihi wasallam have told us. This is the meaning, this is the purpose. If we are unable to do that, in what situations we are unable to do that? Comatose patient, the patient is in coma. They are unconscious. That is not meaningful. They won't be able to do their namaz, their salah. They won't be able to do their rosé, the fasting. They won't be able to do any charity. So no, there is no meaning in life. So for that, I will mention later in my presentation, Allah has given us permission to, withhold and withdraw. But if there is a chance of meaningful recovery, we are instructed to seek treatment. Treatment is prohibited when the burden of treatment outweighs the anticipated benefits, cause severe pain, or violates human body's integrity. A patient who is not conscious, but they have their tube in, tracheostomy, they have a feeding tube in. They are at home with that home ventilator on. But yes, they are not responding to you, because they are there in that state. So the benefits are lower, the burdens of the treatment are higher. Like they are getting this artificial, prolongation of life. And this also causes them severe pain and suffering too. Treatments is permissible or optional when it is neither obligatory nor prohibited. Let's talk about end of life. So quality of life, you will see us talking about quality of life. So quality of life is a noun which means standard of health, comfort and happiness experienced by an individual or the group. Preserving physiological life, like I gave the example, a patient who is not conscious but they're at home with the tracheostomy tube and a feeding tube in, and they are there. They are just alive, but they are not interacting to you, they don't know what is happening around them. So that, continuing that life, that the heart is working, the brain is working and everything, that is physiological life. So preserving physiological life is not a worthy goal in or itself in Islam. The goal of care is to maximize the chance of an individual to regain their status of a morally accountable person, as I mentioned earlier. They are able to do their namaz, they are able to do their roza, they are able to give charity, they do X that will make Allah subhanahu wa ta'ala happy. So that is a morally accountable person, because if they don't do it, they will be held accountable in front of Allah subhanahu wa ta'ala. So if the person has lost that ability of morally accountable person due to illness, then there is no point from Islamic point of view to continue their life by artificial means. Death in Islam. And I tell you, when I have patients from Islamic belief and patients from non-Islamic belief, usually the care team asks me, oh, if the patient is passing, we have to get ready, they will have so much grief, there will be so much crying, so we should be ready about that. And when I was working in Minnesota, I had a patient, a baby, from a Muslim baby, and I told them, you will see the way Muslim grieve is very different than what you see here. So the outlook of death in Islam is generally positive, because we know that when we'll die, we are going to meet Allah subhanahu wa ta'ala, whom we are waiting to meet since we are born. And we know that death is the will of Allah. To Muslims, illness is not seen as a wrath, but as a normal consequence in life. This is reflected in the powerful Quranic verse from Surah Al-Baqarah, verse 156, to Allah we belong and to Him is our return. We Muslims believe that death is the departure of the soul from the body by divine decree that Allah subhanahu wa ta'ala, that marks the transition from one state of existence to the next and the beginning of the journey in the life hereafter, which is perpetual and infinite. And then the whole life we prepare for that journey, that infinite life. It is, as we all know, in Muslims it is always announced with the remembrance of Allah, and we accept the death of a loved one without going through classic stages of grief. Delaying death with futile or hopeless treatment is unacceptable in Islam. Prophet Muhammad said, none of you should wish for death because of a calamity befalling them. But if they have to wish for death, they should say, O Allah, keep me alive as long as it is better for me, and let me die if the death is better for me. Terminally ill Muslim patients are permitted to have life-sustaining treatments withheld or withdrawn. Withheld, Rokhlia; withdrawn, Nikalia. And these happens when the physicians are certain about the inevitability of death. Treatment is not obligatory, would not improve the patient's quality of life or their condition, involves great complication, delays the dying process, or involves suffering. So all these things are legally determined, and you will see Dr. Kiriwala will discuss about that. So when we get consulted as clinical ethicists, we ask the physicians, we ask the care team, do you think that this treatment is causing so much burden on the patient than any benefit? And the burden is like prolonging the dying process. And if they say, yes, it is prolonging the dying process, generally in the Western bioethics, we say, yes, it is permissible to go ahead and withdraw treatment. If a patient is Muslim, we make the reference and say it is permissible in Islam to withhold or withdraw life-sustaining treatment in those situations. But it is very, very important that it is a collective decision acquired on the basis of informed consent after consultation with the patient's family and all the individuals involved in patients providing care to the patient. So it's not like unilateral decision of a physician that, oh, this patient, I don't think the patient is going to recover, so we should withdraw the ventilator. No. This decision should be made in collaboration with the family, because the family knows patient's values, wishes, and preferences. And it has to be a collective agreement. The physician is not losing a loved one. The family is losing a loved one. So they have to be on board. They have to be on the same page with the physician that, yes, we agree, in this situation, continuing life-sustaining treatment is not going to benefit and it is causing prolongation of life. At any point, if you want me to explain anything in Urdu or stop and explain again, please do let me know. So So advanced care planning, importance of writing your will. 63% of US adults haven't completed an advance directive. Among Muslims, the number is likely even greater, meaning most American Muslims will leave vital end-of-life decisions to healthcare providers they have never met or to the family members who may struggle with uncertainty over their wishes. The Holy Quran and Sunnah point to a pragmatic approach to advancing age or declining health. Death is described as Allah's design, part and parcel of life's test, which can affect any stage of life. Allah says in Surah Al-Imran, verse 185, every soul should taste death, and you will be paid in full only on the day of resurrection. Whoever is kept away from the fire and admitted to the garden will have trumpet. The present world is only an illusory pleasure. By being a sign of Allah's plan, such teachings allude to aging or illness as worthy of our observation, thought, and planning, as well as being a general reminder for the society at large. Death is unpredictable and can happen at any time, and as such, Muslims should always be prepared for the inevitable and for what is about to occur. Prophet Muhammad ﷺ said, the one who remembers death the most and are the best in preparing for what is after it, they are the wisest. So it is important, very important to write your will. If you are not writing your will, at least convey your wishes, values, and preferences to your loved one. We are all in Illinois, so you have seen the Illinois surrogacy hierarchy. Your spouse comes next. If you have a spouse, your spouse comes next. Let them know what you want. When you are unable to make your decisions, you are on a ventilator, and the care team is saying that we should take the ventilator away. They should know if you want to continue or not. If you are not letting them know that, you will be a vegetable. They will be doing all those procedures, poking you, prodding you, causing you pain, and they will not know what to do. So it's better to tell them what you want. And those situations are very painful for the family. No wife or a husband or no son or daughter would want their mother, father to pass away. They would want them, hold on to them till they can. But this is not permissible in Islam if the parents or anybody for whom they are making the decisions are unable to recover and to have a meaningful life. So this is the power of attorney for healthcare form for Illinois. I recommend you all to have a look at that. Please fill it and please give it to your healthcare provider. I know in our South Asian culture it is not very common, but it is very important. And now you know its significance in Islam. Islam always asks us to prepare ahead. And death and end of life is a very complex situation. Something very important about pain control. In Islam, saving a life is encouraged and reducing suffering with analgesia is acceptable, even if in the process, death occurs. So saying that, oh, please don't give morphine to my loved one, they will die, and then you are going to kill them. Or people will say, I killed them. Or Allah will say, I killed them. No. Preventing them from suffering and pain is very important. As we all know, amal ka daramadar niyat par hai. Our acts are based on our intentions. So the intention is not here to kill the person. It's to relieve their pain. And Allah knows that very well. We do not need to tell Allah that that's the reason we are doing it. So this rule is based on the central teachings that administering pain medication that induce temporary or partial loss of consciousness are permitted, but those that cause permanent loss of consciousness are not permitted, as the person loses the cognitive ability, their own brain's power to think, reason, and ability to perform willful action. And again, it is important for a person to know their willful actions, to be accountable for them. And our life is all about what we are doing willfully, and we are able to be accountable in front of Allah subhanahu wa ta'ala. So life-sustaining treatment. Life-sustaining treatments, over the past decades, there have been a rapid medicalization of the dying process around the globe, here in the US too. In developed nations, most people die in medical facilities, surrounded by machines and sterility, rather than in the confines of their homes, surrounded by their loving relatives. Burgeoning technology and medical capacities have contributed to this shift as access to healthcare facilities has increased, and doctors are now able to use novel technologies to maintain the sick person. So the novel technologies are like putting the patient on ventilator. So if they are not breathing, the ventilator is breathing, and the life is going on. If they are not able to eat, they have a feeding tube, and they get nutrition. If their kidneys are not working, they get dialysis, and the body is functioning. So life-sustaining treatment is any treatment that serve to prolong life without reserving the underlying medical condition. As I mentioned, all these CPR, artificial nutrition and hydration, these are all life-sustaining treatment. It is the decision, withholding life-sustaining treatment is the decision not to make further life-sustaining therapies. So it is very important, again, to make sure if the benefits of these treatments are higher or not. If the benefits are not higher, it is not permissible in Islam to continue those life-sustaining treatments. So these are the life-sustaining treatments I mentioned. So as I mentioned about withholding and withdrawing life-sustaining treatment, they are based on ineffectiveness. The purpose is not to unduly prolong lives of the patient when the lives have no meaning due to poor brain functioning, nor it is something that Sharia demands. We are obligated to rescue patients so they can have their life that can benefit their hereafter. मरने के बाद आपने जो भी जिंदगी में काम किए हैं वो आपके फायदा दे सकें. If a patient is unconscious, lying there on the hospital bed with the machine and stuff, they are not able to do anything for their hereafter. So this means that they have lost the purpose of life. So anything that has lost the purpose, for those situations, Islam says, do not prolong life. Do not do that. So as I mentioned, for the brain death, this is a new thing. So brain death is like permanent loss of capacity of consciousness. Again, you are not able to do anything meaningfully. So that's why brain death is considered legal death in the US, and it is a death in Islam too. So this is just like quotes from the Islamic Medical Code of Ethics about withholding and withdrawing life-sustaining treatments. And these are all the fatwas that are present, which says that it is permissible to withhold or withdraw life-sustaining treatment in cases when there is no benefit to the patient. So this is just a flow chart which says that are the chances of recovery to a conscious state probable? Yes. Then it says continue treatment. No, it is permissible to withdraw care. Do the treatment harms outweigh the benefit? Yes, it is permissible to stop the treatment. If the benefits are higher than the risk, it is permissible to continue treatment. Hydration and nutrition, I'll quickly touch on this. So nutrition and hydration can be understood with a broader duty to feed the sick. It is never permissible to withdraw procedures designated to alleviate pain and promote comfort. If hydration and feeding is stopped, the patient does not die peacefully and comfortably. They suffer from dehydration and hunger. So here in the US, they say no, the patient will suffer a lot, so we should stop every kind of hydration and nutrition. Islam says go with what the medical treatment is saying. So in these situations, it is permissible in Islam to give them trickle of water at the time of death, so their lips and their tongue is moist and they don't feel the thirst. As I mentioned, so the personhood is very important in Islam. If the personhood is lost, the person is considered dead. So in brain death, the heart is working, but the brain is not functioning. And everything is, related to brain, are all acts, are conscious act, अच्छी बुरी चीजें, सारी दिमाग से related हैं. So if the brain is not working, it is considered death in Islam. And then these are the resolution of Islamic jurisprudence from Oman mentioning that brain death is legal death and death in Islam. And these are all the fatwas that are supporting this. So this is per IMANA, the Islamic Medical Association of North America. If the person is dead when these conditions are met, a physician has determined that after a standard examination, a person's cardiopulmonary functions have come to a permanent stop. Cardiopulmonary, their heart and lung has stopped. A specialist physician has determined that after standard examination, the function of brain, including the brain stem, has come to a permanent stop, even if some organs may continue to show activity like heart. So if that has happened, it is considered dead. Quickly, touching on organ donation, Islam instructs all the Muslims to save life. Organ donation and transplantation is allowed for the purpose of saving life. It is an act of charity, and donating organs from a dead body are not equivalent to mutilating of the dead body or an act of disrespect. It is very common in our community that we say, no, the person, the way they came, they have to go back to Allah subhanahu wa ta'ala like that. If you are taking any organs from them, you are disrespecting that body. No. Islam put great emphasis on saving the life. If you are saving someone's life by donating your heart or your kidneys or liver, you will get Jannah, inshallah. So that is the core principle of Islam: save life, do charity. This is the statement of Fiqh Council. These are all the fatwas supporting the organ donation and transplantation. So summary, it is not imperative on a Muslim to seek remedy except in life-saving situations and where the illness is due to infection for which treatment is available. The patient should be treated even against their will if it is going to infect the other people. In Islamic jurisprudence, completely stopping nutrition and hydration is a clear case of murder. Seeking palliative care is permissible in Islam. Treating pain is encouraged. Use of analgesia, that is pain-relieving medication, is permissible if they have side effects like death, as the acts are judged on the intentions, not by their outcomes. Stopping or not starting certain treatments or certain types of management are allowed if the treating physician finds a certain modality of treatment non-beneficial or going to increase the suffering of the patient. Stopping certain measures that support life or not starting these measures like DNR or do not intubate, these measures are accepted if decided by at least 3 competent specialist physicians. So you see there is like a group of physicians, not one physician deciding, oh, we should not do CPR on this patient. Group of physicians so that it is fair to the patient. The medical decision should be fully explained to the family, but it remains a medical decision. So if the family say, no, we don't want to do that, but the physician is saying, no, we should be doing that, and we are medical experts, we should be listening to the physicians. Active termination of patient's life, that euthanasia, is haram, it's not permissible. Brain death is considered death in Islam. Organ donation and transplantation, blood, plasma donation is permissible in Islam and is considered as an act of charity. Too much information in short time. I know you can ask me so many questions. So I would like to end with this dua. Oh Allah, make the best part of my life the last part, and the best deed the last deed, and the best day the day I meet you. Jazakallah khair for listening, and sorry for my shortcomings. I am open to questions.
So I'd like to introduce now Dr. Nilofar Kidawala. She is a native of the MCC community. She graduated from MEC Sunday School and volunteered as a teacher there for several years. She is board certified hospice and palliative medicine physician. Dr. Kidawala currently practices palliative care at Advocate Lutheran General Hospital and hospice care at Rush University Medical Center. If everyone can please just take a seat and quiet down for our next speaker. Thank you.
Assalamu alaikum. Jazakallah khair for having me here, for everybody attending after dinner and staying to listen. Inshallah, we'll kind of review some of the points that were already made during the first part of the presentation, but then inshallah to talk a little bit more about how palliative care specifically, but then even hospice care is helpful for patients in life and towards the end of life. So the objectives for my portion today is to review what palliative care is and to review what hospice is. We're going to review what it means to talk about code status, specifically what DNR is, and referencing the pink forms that everybody is seeing on their tables. We'll review the definition of power of attorney for healthcare. Again, there's a form that I think most people have gotten on their tables, but again, we'll just review that briefly. I was asked to define what euthanasia is, so I thought I would also provide just a little bit about what medical aid in dying is, and how, again, this is different than what was previously discussed regarding withdrawal and withholding of life-sustaining treatments. And then lastly, I just wanted to review some of the common challenges a person faces when dealing with the end of life, but specifically too, maybe even for our younger generation, and as we see our elders aging, how the care of our loved ones change, and how we need to start preparing for those times. So palliative care, I will tell you, anytime I go see a patient in the hospital, they have no idea what I do and why I'm there to talk to them. So I'm hoping that after we talk for a few minutes here today about it, you'll know at least what this specialty is. So palliative care is a specialty of medicine. It's working with patients that have serious medical and chronic illnesses. So as listed here, there's a lot of chronic medical issues that people may have, from their lungs to their heart, from the brain with dementia, people that have had stroke before, and really the role of a palliative care physician or nurse practitioner, social worker, clinician in general, is to work alongside of the other medical teams caring for a patient and really to provide support. So support typically happens kind of in two ways. The biggest portion that patients actually feel is symptom support. So people that are dealing with chronic illness, with cancer, with COPD, dementia, they have symptoms like pain, depression, anxiety, constipation. So these are symptoms that a palliative care physician or provider might focus on and try to really help support a patient and alleviate some of that discomfort, some of that suffering that they're having from those symptoms. Again, alongside of their other physicians, cardiologists, their kidney doctors, whomever they're seeing. The other portion of palliative care is a little bit different. It's actually kind of working with patients, working with their other doctors, working with families to help people understand their chronic illness and what's going on in their lives. This is challenging because I think, again, as people are sitting in this audience, they themselves might have chronic illness and they know this tale maybe too well. And there are others that maybe, alhamdulillah, don't have any medical issues, and so they have no idea what I'm kind of talking about right now. But there are people as you age, or even when you're young, you're faced with a really tough medical problem, sometimes a new medical problem after that, and one after that. So my role as a palliative care physician is working with people to kind of understand what each of those problems mean, to answer questions about their medical condition, but even to talk about what's going to come next, right? We cannot predict everything. We cannot necessarily predict a person's time to the minute, but we can understand what is going to occur because we see how chronic illness impacts a person, how sometimes this leads to hospitalization after hospitalization. So my role is working with patients and working with families to explain what's going on, right? If there are questions, maybe ask the heart doctor. We don't understand why this is happening. Can we get more information? I don't understand why I can't take this kidney medication. So we might communicate with two different doctors and get that information. But the other piece too is talking with families. Sometimes I meet with patients, but I also ask them to bring their son, to bring their daughter, to bring their daughter-in-law, whomever, to kind of understand what's going on medically and again to understand what's to come. I'd like to talk about a patient that I've actually recently been taking care of. Mr. L, he's a 62-year-old man, head and neck cancer. And this is the reason that I was seeing him. He actually came to my office. He already started radiation treatment, but he was having really significant pain. pain in his tongue, pain with everything that he would swallow, everything. And he was really struggling with his disease. So his oncologist asked me to meet him and to try to focus on some of the symptom management. So what did I work on with him? We worked on pain. We worked on kind of getting better pain control so that he wasn't struggling so much day in, day out, even at night with having such a dry mouth. And the other thing that we worked on too was kind of just understanding his condition. So I saw him about once every few weeks. We kind of tailored his medications. We came to a regimen where he was kind of having a better sense of his pain, when to take medicines, and what was helping. He also was exhibiting some symptoms of depression. A lot of things were changing in his life. Going to work was becoming more challenging for him. So through some conversations, also with our social worker that works with me, we started the patient on some antidepressant medications, but also asked him to see a psychologist for some additional support. So unfortunately for this patient, the cancer continued to progress to his lungs, and he was starting to have other symptoms. So one of the biggest things he was complaining of was shortness of breath. So he was seeing me in the office. Pain was still on and off a problem, difficult to kind of fully manage. But then also shortness of breath was becoming problematic. So again, we were working with different medications to try to see if we can alleviate some of that suffering that he was having. His wife also came to the appointments. It was helpful to have his wife there because some of the things that she was sharing were things that he wasn't sharing. He, at one point, couldn't go to work anymore. So things were changing for them, and they were also changing financially. So it was an opportunity to kind of talk about what that meant, even to find resources of how to pay rent and other things like that with people with kind of tough diseases. He then called me maybe a couple weeks after that and was complaining of something completely new. Leg cramping, really significant pain, and weakness. He couldn't even stand anymore. And this was a pretty active guy, so I already knew that that was a big change. I told him, you need to go to the emergency room. I don't know what's going on right now, but this is something that you need to be evaluated for. He called his oncologist. The oncologist said the same thing, go to the emergency room. So he did. He got some imaging, and they found a new, essentially, cancer in his leg that was so significant that we were concerned that it would cause a fracture, right? So it would break. So there were a few more doctors that came to see him. His own cancer doctor was seeing him in the hospital. Also the orthopedic surgeon was consulted to kind of understand, is surgery an option for his leg to prevent a bigger problem and a breakage? With the conversations that we were having, with how advanced the disease was already, the oncologist came to the point where he was seeing that the risk of doing further treatment with chemotherapy and other agents was actually becoming more burdensome for the patient. He felt that ultimately the risks were outweighing the benefits, that the patient's time was actually becoming shorter, and he recommended a different approach moving forward, and he recommended hospice for the patient. So what we did was we had a meeting. We had the patient, his wife, the orthopedic surgeon, the oncologist or the cancer doctor, and myself, and we talked about what this meant, and we also talked about why we were recommending hospice. So hospice is a word that people may or may not have heard, but really what it is a support for a person that has a limited time. Okay, the definition is less than 6 months. That's kind of the Medicare guidelines of what's utilized, but it's somebody that has a disease that is progressing and that ultimately their time is probably less than 6 months, so this is a support that they can have. So it's a support in the sense that the goal is completely different than trying to cure an underlying disease, but rather to focus on what was previously talked about, quality and dignity for an individual. Pain management, any type of shortness of breath management, really trying to understand that the goal is to help a person stay at home or in their home setting and not necessarily come back and forth to the hospital, because ultimately their underlying disease is not changing and that they will still weaken and their time is still going to come. So just to kind of better understand what hospice is, it's a physician typically as the medical director, a nurse that's making visits to a person in their home setting a few times a week, a nurse's aide, sometimes social worker, a chaplain, a volunteer. What they do is they make visits to a person, okay? What they help with, again, is assessing how the body is changing as the body is weakening, and prescribing medications again to alleviate that suffering during that time. What the most beneficial thing for patients truly becomes is that hospice becomes a person's 911. Ultimately, if a person's at home and they have a tough disease and their doctor said, okay, you probably are only going to live for maybe a few months or a few weeks, and a patient says, okay, I want to die at home. Well, when things start changing for that individual, right, they're not as responsive, or maybe they are having a lot of increased pain. Without hospice, a patient or family, they don't know what to do. They don't have the medicines to help them as things are changing. And so ultimately, if they don't have hospice on board, the family, rightfully so, will call 911 and they'll go to the hospital, right? But at the hospital, ultimately, as I just said, if they're that far advanced in their disease, things are not going to change. And so with hospice, a person has the ability to call anytime, 2 a.m., 2 p.m., it doesn't matter. And what the team is going to do is they're going to evaluate over the phone as they're coming to the home, okay? As they're coming to the home to actually evaluate to see what's going on with pain, what's going on with shortness of breath, or agitation, how is a person changing, and what can we do about it? The goal trying to be, again, to alleviate that trouble, alleviate that suffering, and trying to keep the person at home. It may not always occur. They might need more symptom control that can be done at home, but for the most part, it's something that usually can be done and is the greatest benefit within hospice. So my patient, he actually declined the recommendation for hospice. He said, you know what? This is not for me. I don't want it. I hear what you're saying. You're telling me my time is short, but I don't want to do that. I want to go home. I want to see you. My cancer doctor, he's telling the oncologist, I want to see you in the office, and I'm going to get stronger. And the orthopedic surgeon didn't think that he should have surgery for his leg. But he said, if you want to think about it, you can also see a different doctor at a different hospital. So he did. He went home. He saw a different doctor at another hospital. He actually did have surgery on his hip to prevent that breakage there. And he was still calling me once a week because his pain was still increasing significantly. He wasn't doing well overall, but he was home, and that's kind of how he wanted to be. He was coming back and forth to the emergency room with pain. He was coming back and forth to the emergency room because he couldn't breathe. So that's why he kept coming back. It was probably about 1 or 2 times per week, just for a few weeks, until he came in again. This time his oxygen was actually really low. He wasn't feeling well at all. I went to see him in the emergency room. His oncologist came to see him in the emergency room, and we talked to him. And we said, we're really worried about what's going on. You're even worse than you were just a few weeks ago. We think that your time is coming. And he knew it inside. He said, I know. I want to go home. And so we did what we were recommending just a few weeks back. He made the referral to hospice. He was discharged from the emergency room, and that was kind of how it was going. A few things that we talked about in the time during that time was kind of some of the stuff that I brought in with you just to kind of understand some of the topics that are discussed when a palliative care physician or even any other physician might talk to you. What we recommended for Mr. L was for him to be what we call a DNR, or do not resuscitate. Whenever his time came, we said, we want you to have a natural death. We don't think that you should be on a machine to keep you breathing. We don't think we should be doing compressions on your chest to try to restart your heart or to use electricity and shock your heart. Ultimately, what's going to change is nothing. You're still going to die. And he did agree, okay? In the emergency room, we did fill out this form. You can see it on your tables there. It's a form that actually is utilized as a medical order for physicians and paramedics, firefighters, for people to respect a person's wishes when it comes to the time where their heart stops or they're not breathing anymore. And so this form, and please feel free to read it, take it and review it with your own primary care doctor or whomever you think is appropriate to review it with. But ultimately what it's saying is what your wishes are if you're so ill to the point that your heart stops and you're not breathing anymore, which means at that time you would have passed away or you would have died. So this form gives guidance to the medical team, and it's actually a medical order, so they can honor this wish. What's important and why it was important for my patient was he was going to go home, and we were recommending hospice, and he agreed. But without this form, if 911 is dialed, which it shouldn't be, because if you're on hospice, they become your 911. But if somebody calls 911 and this form is not there, the paramedics are obligated to perform resuscitative measures. That's something that they have to do. So again, if it's important to an individual, we say you should complete this form. It does require a physician signature, so it's something that has to be done with the physician in congruency. The other thing that I recommended for the patient to do is the other form that you might have on your tables, and I think we didn't have that many copies, and maybe we'll get more, but this is something you can Google and find too. This is the power of attorney form that was addressed earlier. Basically what this is, it's saying who's going to make medical decisions for you at the time that you cannot make them, right? So who do you trust? Again, there's already a law for Illinois, so it'll follow that law, and so if you are married, it'll be your spouse. If you don't have a spouse currently, it's your adult children. It kind of follows from there. But sometimes a person has 4 kids, and 2 of them are always against each other. So maybe you want to choose the 3rd one, at least to be the spokesperson. Ideally, everybody's talking, right? But this is something, again, that physicians can look, or providers can say, this is the person who's going to make that final decision, whatever the decision is. Whether it's to start dialysis, whether it's to do CPR or not. It's these kinds of decisions that the power of attorney will make. So again, it's a good form to complete, really for anybody. And the only caveat with this form is it does have to be witnessed by somebody that's not related to you and not part of your healthcare team. So like not your doctor or not the nurse that's in the doctor's office. It needs to be a neighbor or a friend that's the witness. Otherwise, it's a completely legal document. So this is another form that I asked Mr. L to complete, and he did. He named his wife, and then that was done. Because of that shorter prognosis of essentially weeks, he decided to go home. He did have hospice support, and his family was around. They had to hire a caregiver to help support him and kind of care for him as his body was weakening, and he died 3 weeks later. I think sometimes it's important to talk about what dying actually looks like, and it's different for everybody. In my job and what I do, I unfortunately and fortunately have seen people die, and I've seen the process of dying, and it's very different. So I can't say specifically this is how it's going to be for everybody, but ultimately what it comes down to is the body shutting down. Which organ's going to shut down first? I can't always tell you that. Is a person going to be talking until they die? I also cannot answer that. But ultimately what it is the body is shutting down. What we see are things in a person's awake self. Are they still talking as much as they were before? Now they're sleeping a lot more. These are some more common things that we see. Again, they're sleeping a lot more. They're not eating as much, right? Or they just stop eating completely. And this is, again, a very natural thing to occur. What was mentioned was kind of like, okay, we should help a person with nutrition or with hydration. You know, a lot of people, they have IV fluids sometimes towards the end of life if they're in the hospital, or sometimes they even have like a feeding tube, you know, either in their nose or in the stomach that's giving temporary feeds. And so in these situations, again, there are times where those feeds become burdensome to the dying body, because the body is changing. The body doesn't require the same level of nutrition that it needed to function previously. And so oftentimes a physician is actually recommending we should stop this treatment. We should stop this IV fluids, we should stop this feeding, because it's causing more harm to the patient. And so in that situation, again, harms are outweighing the benefits, it's appropriate to stop. But even as a person is dying, right? You don't have any feeds, you don't have any IV fluids running for that person, you can still moisten their mouth, right? You can still give them that pleasure even as their body is changing. And it's something that we encourage in hospice, but in general for anybody that's in that process. The other thing that people notice is the breathing pattern of a person changes. Sometimes they're breathing very fast, sometimes they're breathing very slow, sometimes there are pauses in between the breath that makes you question what's going on, but ultimately this can change. And I say all of these things because also too, people have symptoms that come along with this. Really bad pain sometimes can be associated with this dying process. So the goal within any of this treatment that we're trying to do is to alleviate that suffering, to alleviate that pain with different medications that can help a person during that time. Other symptoms that become challenging would be shortness of breath, sometimes agitation. These are tough things that are something that can be challenging for a patient, but even challenging for family as they're trying to take care of someone during this time. I wanted to just briefly touch on this, just to kind of again reiterate what we already said before. So euthanasia is essentially the act of causing a person or an animal's death in a merciful way to end suffering. That's illegal in the United States. It's not done. There's something different called medical aid in dying. It's also known as physician-assisted suicide or physician-assisted death. It's a little bit different in the sense that this is where a physician actually provides a prescription for medication that a person takes themselves to end their own life. Okay? This is actually legal in 12 states in the United States. It's not legal in Illinois. The only reason I'm bringing this up is to really kind of hone in on the point that this is different than one of the biggest things that we are facing as our generation is aging and as people are making different decisions. This is very different than withdrawal or withholding of medical treatment. Okay? When a person's like on a ventilator, they're in the ICU, they're on medications that essentially are doing the job of their heart and keeping them alive. And you have one physician, two physicians, three physicians, groups of physicians coming in and telling a family, we're worried about what's going on, their body's already shutting down, we don't think that this should continue. This is a different kind of a decision about turning off a machine, right, that's doing the job of their lungs and giving them oxygen in that way. This is different. It's not a person making a decision that's actually leading to that person's death and making it happen. It's the body already started shutting down. That process has already occurred. And so you're allowing that natural process to happen. And I tell this to my patients on a daily basis. And again, it's whether somebody wants to believe me or not, that's their own right, and that's the way that they're interpreting their own way of understanding the medical care, but also the way they're interpreting their religion and their deen, right? But this is occurring. The body is shutting down and it's allowing it to happen. So if you're turning off a machine that's being recommended to do so, it's an appropriate path to do. And it's different than causing a person's death or giving them medication to cause their death. I just wanted to end by reviewing some of the challenges at end of life, both for a person and for people that are caring for them. Again, it's kind of understanding that death is inevitable. We know this as Muslims, this is not a question, but it's also possibly imminent for some, right? And it's listening to those that have more knowledge and understanding that sometimes the chronic illnesses, the different problems, the heart issue, the lung issue, the kidney issue, you add them all together with the new stroke, that may be a person's body starting to shut down, right? And so this is something where we kind of need to understand that we need to better understand medically what's happening, listen to those people that are providing the information, and then make decisions with that information. One of the points that I kind of see day in and day out is I think that, you know, humans, it's not even just Muslims, but humans, we all wish that we could die in our sleep, right? We just died and nobody had to make any decisions, nobody had to suffer, we just died. And that would be really nice if that happened for everybody in one way, right? But it's not how it's happening, you know? The body is shutting down in different ways. It's not just the heart that stops, right? It's so many other things. And this is really challenging for individuals, Muslim patients too. This is really challenging for people to understand. That if your heart is not functioning like it was before and you require a medication literally to do its job, your body is starting to shut down, right? It's a different definition of dying, right? Or you can't even maintain your blood in your body anymore. So now you are getting transfusions of blood once a day, once every few days, because otherwise your body is literally shutting down. This is another form of dying, right? And so this is a conversation that you need to be prepared for potentially, depending on your medical illness, to understand what it means and what does it mean to die from these kinds of conditions. The last thing I wanted to touch upon is a little bit for those, again, that are getting older in their time and maybe have more chronic illness, so they're kind of seeing or thinking about their own death. But in truth, it's even a reminder to myself about my own loved ones that are aging or changing in their medical conditions. but specifically even just more so how things change as people get older. People need help. You know, again, I'm seeing patients at the hospital, I see patients in the office, and they come by themselves, you know, or they come with their wife only. They're 82 years old and the wife is 81 years old. They drove themselves to the appointment. The patient is going to their own chemotherapy with their spouse driving them. They're still doing everything that they can for themselves. And then I ask, who's your family? Who's your support? Oh, I have 3 kids. Yeah, they live locally. Yeah, we have 8 grandchildren. And it's nice to hear it, right? They're proud of their family. But it's not often that you see them coming to the appointments, right? It's not often that you see them driving them to the appointments. And I'm not saying that everybody's not doing it, but I'm even speaking to my own self, right? As our generations are getting older, people need help. And I think, again, this is an opportunity for us to reflect on this and think about how we can help others in these kinds of situations, even just for our own family, friends, and neighbors, different kind of situation too. Even beyond this, there are things that are also changing, even in terms of finances, right? How are people affording the care that they need? My patient, he only had a spouse. He had no children. He had a few friends, but they weren't that much. They didn't have much money, but they did have to hire somebody to help care for him because his body was changing and his wife could not physically help him as his body was shutting down. So again, conversations, right? What kind of support does a person need? Who's gonna pay for it, right? Where is that money coming from? These are sometimes more challenging conversations to have, but important, because at the end of the day, this is the practical piece when people are changing, when their death is approaching. And so again, I encourage the younger generation to start thinking about it, asking the questions, but even to the older generation to ask for help. I tell my patients all the time, be specific with the help that you need. People are always gonna say, oh yeah, do you need anything? Let me know if you need anything. Who's gonna say I need something, right? We never do. The moms know, moms never ask for help, right? People feel very independent and strong, so they don't ask for help. But when things are changing, right? The body is shutting down, your spouse is dying, and you don't know what to do, right? Maybe you just need somebody to come to your house and sit with you. Ask, say, can you just come and sit with me for a little while? Or tell your son. That's the end of my talk. Thank you.
Dr. Kiriwala, that was very insightful. We do have some questions we're going to go over. So a lot of people wrote them down on note cards, but I want the people who didn't have the opportunity to write it down that we're going to pass them mic as well. We also did make copies of the power of attorney for health care forms. They're going to be up here if anyone needs them. Just let us know. We can pass this out as well.
So we do have a question from the audience.
Hi, thank you so much, Dr. Kiriwala. I'm a physician too, and your last point is exceedingly what I see more and more. You know, the 80-year-old couple, they've been together for, you know, since they were 12 years old. They were childhood sweethearts. He drives her everywhere. He handles all the bank accounts, the checkbook, the bills, and now he has a problem. And so, well, yeah, we have the kids, but they're working full time because everything is so expensive. We have to pay the rent, we have to pay the mortgage. So I just wanted to add, like, what I ask people, and I have to do this in my own life, because we have these chronic illnesses that we are living longer, but we don't have the same functions sometimes. We get weaker, we can't walk sometimes, we can't do the things that we need to do to be functional. So what I might pose, and I don't know, maybe you can comment on this, or if you phrase it a different way, is consider if you weren't able to do for yourself, or for your husband, or for your wife, say somebody could not walk, and could not prepare a meal or clean, or even get out of bed. What would it look like for your family? How would you prepare for that situation? Who could you identify that could come and help? And a lot of the patients I have are surprised to find out that the government won't pay for those kinds of things. They think, oh, well, you know, hospice will pay for that. My insurance will pay for that. No. So this is a big problem. in our country. I don't know how you would address this audience in that way.
Thank you for bringing that up, and it's actually the biggest part because it's the most practical part, you know. I think ultimately if you can accept that you're dying or that your loved one is dying and then you're okay with it, and you're like, okay, let's let it happen. It's gonna happen, let's let it happen. But then there's always the part of, well, where is it gonna happen? Who's going to actually help? And yes, who's gonna pay for it? So the reason it's brought up, and thank you so much for bringing that up again, we do need to talk about it, right? It's not covered, right? This kind of care, physical care for a person that has chronic illness or one that is actively dying. It's not covered by any type of insurance, sometimes a long-term care plan, but even that, it gets really tricky. So you need to start thinking about this. And there's really no way specifically that I can give advice to people except for think about it ahead of time and start planning, just like we plan anything else in our lives.
Did you say that long-term care will not?
There are some long-term care policies that will, but every long-term care policy is different. I just had a patient that had a very high deductible that was associated. So this is what I'm trying to say. It's always individual for the patient. If you have some type of policy, go read it before the time comes, right? Because you should know these things before that actual situation occurs.
I'm Jalal Beg, in medicine as well, oncology. I know Dr. Kiddiwala, very difficult but necessary topic, especially from the perspective of an oncologist. One question I have for Dr. Kiddiwala is, can you explain the differences between hospice and palliative care and why they're not the same thing? And why it's sometimes, what's the virtue of perhaps opting into palliative care before hospice? And the second question is hospice only available for people that have cancer? Or is it also available for people with other medical illnesses such as chronic illnesses, heart failure, liver cirrhosis, things like that? Thank you so much.
Excellent questions. The biggest challenge is helping people understand the difference between palliative care and hospice. The biggest difference ultimately is hospice is for an individual that has a shorter time, right? The definition of about 6 months or less if their disease follows its natural trajectory. So what disease? It could be cancer, it could be heart failure, liver disease, kidney issues, a stroke, dementia. It could be any disease, but essentially where it's anticipated that a person's only going to be living about 6 months. They can live longer. Again, we cannot fully predict, but this is the biggest difference. How it actually plays a role is for people with hospice. They essentially are trying to avoid coming back and forth to the hospital, and they're not pursuing the treatments that are life prolonging or trying to cure those diseases that are causing that change. So to give the example of a person with cancer, they're no longer doing their chemotherapy or radiation, or maybe they don't even have that available to them anymore. That is a person that is undergoing hospice support, typically at home. With palliative care, they're still seeing their heart doctor. They're still going to their appointments. They're still doing their dialysis. They're still actively managing whatever chronic illness they may have. But palliative care can be helpful in those patients because part of it is helping them deal with their medical condition, controlling the pain or agitation or other problems that they have. But even again, talking about how their body is changing and just start preparing for when that time comes. How do they actually want that path to go? So it's very helpful to have palliative care for people that have chronic illness. You can have palliative care support for years. It is covered by insurance, different policies, but essentially it's support a person can have. Hospice is also covered by insurance, and people that don't have insurance, hospice agencies can help these people through charity care. So it's still something that they can benefit from.
I just wanted to bring this thing up from the counseling perspective, because I get this a lot. Letting go for the loved ones. Can you just shed some light on that? Because we have, a great audience here, and if you can just shed some light on that. It is very, very difficult at that point, letting go.
Letting go is hard, I think, for Dr. Baker, oncologist, or any of the other doctors that are talking to people as they're dealing with their medical problems. We do treatment, partly, again, because of our theme and because of our purpose here on this earth. But we also do treatment with a hope that it's going to do something, that it's going to provide some benefit and and either cure this condition or prolong our time so that we're able to do something. And so letting go is a really big challenge for patients individually when they have to realize that the treatments they've been doing aren't working, or there are no more treatments available, right? This is another challenging piece to kind of wrap a person's head around. But this is the other side of things. How about for the families that also have to let go, right? This is really hard, and I see this every day, Muslim, non-Muslim, it doesn't matter. And so you would hope, again, as we talked about, that we know that death is inevitable, so that maybe things would be different. But in truth, it is hard for people to let go, and it's not something that's easy. It's not something you could tell them either. You just need to be okay with it. The idea is that ideally you talk about things, you have that sense that there's a bigger purpose, that when we die, again, there's a bigger purpose, and you hope that can give them some closure, both for the family and for the patient themselves.
For letting go, I would again say that let your loved one know what you want at that time. It's not easy for a wife or a husband or a son or a daughter or any other family member to make that decision. Please don't put them in that situation. Please fill your power of attorney, your living will, let them know what you want so it's easier for them. We all know that this is a transitional phase we are in, and then we have to be there for the afterlife, but practically facing that is not easy. We can never be prepared to do that. So please, it's very important that you let them know when to stop and when to let you go. Okay, I got a few questions over here. Let's start with the POA. There's a question, does POA need to be notarized to be valid? If the person can't sign, can they put X or thumbprint? Yes, for sure, it does not have to be notarized all the time. So those patients who are in the hospital, they want to change their POA agent, they do it in front of a social worker and the witnesses.
What is POA?
POA is power of attorney. So sorry, we are used to using these jargons all the time. So power of attorney. So if the patient is unable to sign, yes, they can mark X. Sometimes they are not able to do that.
I just wanted to clarify, for medical power of attorney, not for any other types of power of attorneys that exist, only a patient can sign their own medical power of attorney, and it has to be witnessed. If a person can no longer sign, it can be any type of marking they want. Patient that has had a stroke and they can do whatever kind of marking, no problem. But if they cannot do their own signature, and if they cannot voice who they want to make the medical decisions, this is not a legal way, this is not a legal form that you can do. Then it follows the Illinois surrogacy law, which dictates who the decision maker would be in the state of Illinois. So this is again important. If you know who you want to make your medical decisions for you, and you're able to sign your form, do it now. You can change it even if you want later on. But if you're not able to make your own decisions, you cannot sign, you cannot do the form anymore.
Yeah. Is DNR allowed in Islam? If yes, can we put in our living will for the emergency responder to respect the wishes? Yes, it is. That is the reason they have this form. As Dr. Kiriwala mentioned, that if you don't have the form, the EMS will resuscitate you, provide CPR, but if you have this form, then they will know that this is your wish and that they should be respecting your wish. Okay, the other day, is it okay to transport a body overseas or across the states for burial? Again, like even if the patient has died, we have to respect the patient's body. So if like during this procedure, you know the body is going to get rotten or something like that, try not to do that. There is no clear guidance on this because this is a very new thing, but what we have seen happening in the history and nowadays as well, that whenever a person dies, they are usually buried, because that is what Islam encourages, that if a person has died, bury them quickly, jaldi unko dafnaye. So if we are following that principles, you see there are basic principles are present in Islam. So apply those principles. Like transporting a dead body from one state to another, one country to another, saying that, oh, this is my loved one's body, so we want them to be buried over there. This is just a body. The soul is gone. So try to follow what there has been happening on what Islam is saying, because you're not going to do anything with the body. So it is important to just follow the principles that are there in Islam and try to stick to that. And the other question is about, can you elaborate more on organ plasma donation? It was surprised to hear that it is allowed. Is this a recent change? So no, this is not a recent change actually. So this was, as you can see, the statement of Fiqh Council of North America, it was a while ago, to December 2018. But most of the councils have agreed, and the Fiqh Council has agreed that with many individual scholars and national and international fatwas that it is permissible to donate the organs. They have said explicitly that the Fiqh Council agrees with many individual scholars and national and international fatwa council in considering organ donation and transplantation to be Islamically permissible in principle. All fatwas that have allowed transplantation have allowed donation as well. Done with a good intention, organ donation may be regarded as an act of charity. And we have gone through the requirements, and these are all the fatwas related to organ transplantation. And if we can see, it dates back in 1959. So blood transfusion, it was sanctioned at that time. Then again 1966, organ transplantation, 1969. Again, organ transplantation, 1973, allowing harvest skin for unidentified corpus, sanctioning corneal transplant, so it dates way back. And again, it is based on the principle of beneficence, do good, and an act of charity.
I have a question regarding following up with that one. Some people donate organs to survive. Business, is that allowed?
No, that's not allowed. So yeah. So as you see over here, it's written, there should be no sale of organ by any party. No financial incentive to the donor or their relative for giving organs, but a voluntary gift may be permitted, like liver transplant. Let's say any family member has a liver failure. We know liver transplant is not, the person will not die from liver transplant, so they give them a part of that. So it's like an act. For a voluntary gift is okay, but as happens, people buy kidneys, pay handsome amount to others, so for that reason it is not permissible, because our body is an amana from Allah subhanahu wa ta'ala, and we are accountable for everything we do. So actually saying that we do not have any rights on our body that, okay, we can sell this organ, or get that, sell a kidney for money. No, this is not ours. We have to return it to Allah. But it is permissible if it is a voluntary gift and it is going to save someone's life.
So the question's about a coma. Coma is interesting. There's different neurological definitions of coma, persistent vegetative state of unconsciousness. So it becomes a little bit tricky, and it depends on what a person is doing and what they are needing in terms of to actually live in that setting, right? Coma, when they are having still brain activity, they're not brain dead, but they are not doing anything. Perhaps laying in bed, there's no communication, they are unable to follow commands, and doing any type of simple tasks like squeeze my hand, open your eyes, doing none of these kinds of things. And so typically a coma is also kind of congruent with some other type of issue, right? What led to the coma? Well, it's a stroke, or there's some issue where the heart is failing, the kidneys are failing. So kind of putting the picture together, again, a physician or team might be recommending not to continue different measures. Maybe, for example, a person that has a feeding tube in that kind of a situation. Maybe they were in the ICU, they were on a breathing machine, they came off the breathing machine, they're still breathing on their own, but they have the feeding tube providing them nutrition, and that is sustaining the body as the rest of the organs are just slowly deteriorating. And so in that kind of a situation, again, we would go back to the sense of benefits and harms outweighing benefits, and what is the person actually able to do, what's the definition of life, quality of life, what are they doing as a Muslim even. And so in that kind of a situation, if you were to turn off the feeds that are running through the body in that tube, ultimately the body is still shutting down. It's going to continue to shut down, but naturally again, right? It's not that this caused death, death is still happening, right? And it's allowing that to occur.
This is regarding, again, that question of brain death. So there are two things. One thing, of course, like you was asking, we don't bury a brain dead person unless the person stops breathing. So everything is stopped, no cardiorespiratory activity, and then we bury them. So after all activity has ceased. But there is a stable brain dead patient that we see sometimes, where, and most of the times it's motor vehicle accidents we see, which we do everything, everything is done surgically. Everything is done surgically, the patient survives, but he's brain dead. But he's stable. Everything is like a cardiorespiratory activities going on, he's on a trach. You don't do anything, he's not opening his eyes, he's not responding, nothing. We don't know how long he will survive. We are giving him nutrition naturally through a peg tube or something. In such patients, what do we do? If such a patient comes to you and if they want hospice, again, whatever, hospice or palliative care, or we don't want that. We know for sure that the patient, after a few months, we say, okay, this person is not going anywhere. He is still breathing. We are giving him feeds. He's having a urine, a tube, and he's urinating, defecating. We are cleaning everything. He's surviving still. No complications. He's alive. What do we do in such a situation?
Usually those patients are coming back and forth to the hospital, right? Although they're surviving, their body is still changing, their skin is breaking down, right? They're getting pneumonia or different infections because all they do is lay there and they don't do anything.
I have seen caregivers, very good caregivers taking care of them, and they're good, even after months, not coming to the hospital.
And I think ultimately this comes to the definition of, again, number one, what is life, right? What does it mean when there is no output from the body, right? There's no output mentally, spiritually, physically. And then what is permissible in Islam, right, in terms of withdrawal. Withdrawal specifically, as you're stating, the person is staying alive because they have a tube providing them nutrition, right? So is it permissible in this situation to stop the tube feeding? This is ultimately that question that it comes down to, right? And then again, if we go towards the Islamic criteria from that, it is permissible, right? Again, hard to do, but permissible, right? And then again, body's going to shut down and naturally die, with or without hospice, but the body is naturally going to shut down and die. Excellent question, excellent point. There's one question, what is the community centers doing or offering for this kind of care? This topic and talk is probably what the community center is doing for this type of care, just making the community aware of these kinds of issues and problems that we should be starting to think about and talk about if we haven't already. I don't know of any specific type of supports or volunteering or anything that exists within this community or others, but we can look into that if that's something that somebody needs. There was one question again about the euthanasia and the medical aid in dying. The really difference comes down to with euthanasia, again, this is illegal in the United States, but with euthanasia, a physician is actually administering medication that leads to a person's death, like causing the death with the medication they administer. And the other thing that I mentioned was medical aid in dying or physician-assisted suicide, also known as physician-assisted death. This is different in the sense that a physician writes a prescription for medication that a patient has to take themselves. So it comes to the nuance of who is actually putting the medicine in a person's body. That's the true difference between the two. As I mentioned, it's not legal in Illinois, but it is legal in 12 states in the United States. Not legal in Islam to give the medication that leads to a person's death. There was one question, I think it's over there, about can morphine be utilized? Morphine's a pain medication. You hear it a lot of times when people are maybe actively dying or in the hospital or on hospice, and it's a common medication. There's other medicines like morphine that are used, and people get very scared and they say that's causing the person's death, or we don't want morphine. Morphine's a pain medicine, sometimes also used for shortness of breath. So can be utilized if need be.
So I got a question, if a Muslim decides to donate a part or the organ what is the process in a hospital nursing home. So your form, it says that I would like to donate my organs, so you can tick on that. In a hospital, or if you haven't done, like you are asked to do that, the power of attorney, and you can let the care team know as well. So they will document it that you have expressed your wish for your organs to be donated.
There was one question in regards to should a person complete a DNR if they don't have any pre-existing health conditions or medical issues, or is there some type of age recommendation to complete the form, that pink form regarding a DNR, or to not do those resuscitative measures? So there's really no guideline in regards to age of when this should be completed. Again, if somebody does have some chronic illnesses and this is something that they are beginning to think about in terms of what kind of wishes they would want in this kind of situation, great idea to complete. If a person is younger and they need to do this because they have some medical issues, definitely something to talk about with their loved ones and complete. If a person has no chronic medical issues, right, no medical problems, maybe even they also are quite young, should they complete a DNR form? Well, by default, you are what we call full code, meaning if your heart stops or you're not breathing, then all measures would be done to restart your heart. What we find is those that are younger with no chronic illness or acute medical issues, the chance of survival with resuscitation is fairly high, so that should be something that a person should know before they make a decision about DNR or not. If they have questions about it, they can definitely talk to their own primary care physician or any other doc that they're seeing in regards to this.
Assalamu alaikum, Jazakallah khair for the program. I don't have a technical question, but you talked about all the deaths that you have seen, fortunately, unfortunately. I was curious about deaths that you have seen where you saw contentment, and any lessons that you can share for me and anybody here on what you thought went right and seeing that contentment at the end of life.
So the questions about contentment that a patient maybe is kind of exhibiting or having before they die. I think in truth, I've seen it in people that are able to somewhat plan their death, right? You know you're going to die, you've got X amount of time according to the doctors. What are you going to do in that amount of time? And I will say that's probably the one period of time where I've seen people somewhat kind of okay or at peace within their own death that's occurring. Ultimately, as the body changes, the person is less responsive and they're not exhibiting a sign of contentment. I did have a patient that I saw and I was helping take care of in a hospice facility, so in a place, it was actually a rush hospital, and she was dying because of a heart issue and her heart failure. And so she actually had a lot of family with her. She was talking with me. We were having a conversation. She was Muslim, in fact. And then I walked out of the room to talk to the nurse about a different change in the medication, and she died within just a couple of minutes. So she was still talking even up until the point that she died. And again, it's because of a different way that she was dying and her body was shutting down. But there was contentment within her death, again, surrounded by her loved ones, and kind of having that somewhat plan. So things to kind of do, I guess, if you will, if you can have this conversation and plan this. I mean, if we believe in Allah and we want to pray, then we pray. We make dua. These are things that can help us in terms of kind of maybe obtaining contentment. I put it to the flip side with the families. You know, this idea of letting go is really challenging. And ultimately, I think this is the hard part where there's a lot of strife and internal struggle that people feel as their loved ones are dying, as their parents or as their children or whomever are dying. And so this is the part where maybe talking or planning might kind of find a little bit of solace or peace during that situation.
My question is like a follow-up to like a doctor telling someone has like 3 months or 6 months to live. Is that based on like the pressure from the health insurance that doctors, I know a health insurance place, do the doctors have to go through that review to say like push back because there's not going to be any activity, or like the person is not going to survive, so we're going to stop, the insurance is going to stop covering any kind of medical treatment. So does that play into the role of the physician decides to tell the family about 3 months or 6 months?
So the question is about, does payer source or money that's going to allow a patient to maybe stay on a machine or something, does that influence a physician when they're saying a person's prognosis? I mean, it shouldn't, right? It doesn't for me, it really shouldn't for anybody, because ultimately, this is just a decision about when a person's going to die. And again, this is a conversation, again, personally, I'm having multiple times a day. It doesn't come down to payer source. People are talking about how are we going to pay for this person's ventilator moving forward. They are uninsured, they're undocumented, whatever. But that doesn't play a role in the conversation with the physicians are having with the families about how much time a person might have or what kind of life they're going to live or quality or whatever the take might be.
Yeah, but is the health insurance pushing back on the fact that the physician needs to like stop providing services?
No, so ultimately a patient has the right to have their medical care, and in truth, just as I said, we can recommend hospice. We can say your time is coming, we don't think you should continue with these measures, but a patient has the ability to say, no, I want to keep doing this. Or a family can say, no, I want you to keep my loved one on the machine. I want to keep doing all of this. And there's no pushback that the family is getting because there's still a medical need to allow that kind of treatment.
I just want to add from the clinical ethics perspective, and these are the situations when they call ethics to look into the situation. So mostly, it's not the case that the insurance company is asking physicians to, step back because insurance is running out. They are obligated to stick to the standard of care. How is this standard of care is created, again, research and experience and everything. So usually if they say that maybe they have 2 months to live or 3 months to live, it is what the research has said. It's not the insurance company who's doing that. And even in situations where the insurance options have exhausted, social workers step in and look into the other options where they can support the patient. But it usually never comes from the physician side. And if it comes from the physician side, unfortunately, any of the teammates, they can and they usually reach out to ethics to step in and see what is going on.
Jazakallah to both of you. That was quite informative. It sounds like this is a very interesting topic and a lot of people do have more questions. So we do have part 2 coming up September 27th. Let's see if we can get a flyer, but we will post the flyer for September 27th. It's going to be in Elston location, MCC in Elston, 4:30 to 6 o'clock, inshallah. At that discussion, we'll be mostly talking about a funeral committee, what the next steps would look like, who do we contact for burial sites, different information like that. So Jazakallah again for your time.